let's get started today. We've already had a few people join in. Bart Robinson, my BJJ, sharing some about a stenotic aortic valve and the impact or maybe lack thereof of vitamin K2. I don't think K2 is going to be powerful enough to positively impact a valve. As Joe has shared, several others, we know that calcification can impact the aortic valve. You tend to see that more often in folks that have world-class Lp(a), and again, we've got several of those in our viewer population. So, speaking of calcium in vessels, let's talk about the topic for today. It's one of my favorite topics, vitamin K2. So today we're looking to clear up some of the confusion about vitamin K2. Does it take calcium out of the arteries, or does it impact insulin resistance, or maybe it's something else? It's interesting. Out of all the K2 videos we've done, I have continued to want to cover one which talks about insulin resistance. I thought I had only seen one actual randomized clinical trial, but as you'll see today, there's maybe more out there which deal with the specific issue of K2 and insulin resistance. But we'll get to that when we get to it, when we get to the program. Again, just a brief reminder of previous topics.
Hello, Doc. You're not sharing your screen, Doc.
I'm sorry?
You're not sharing your screen.
Okay, thank you so much. Hold on just a second. We will get that up there. Thank you, Aspen. Can you see it now?
Yes, Doc.
Very good. Okay, so again, where we left off was talking about previous topics. How to prevent stroke, exercise, and more. Can vitamin D lower COVID-19 risk? That's actually been one of our more popular videos. We've gotten, what, 7,000 or 8,000 just in a few days. And that's interesting because it covered the entire program of one of our YouTube live videos. And so it was almost, what, 15 minutes? A long video for YouTube. But again, getting a lot of views and a lot of time on the view. And like the last one that we did, saturated fats, good or bad, it's a big topic. It's been very popular as well. Now, just to share a couple of other things, way to access our information, and even more so, way to access the information about you. That's what the webinars are all about. You know, people say, well, Doc, it's really expensive to get one-on-one time with you. It is, and that's just the reality. I am in retirement, and anyhow, won't go down that path in terms of talking about, I've got patients all over the world, and anyway, so here's one of the things that we've done. So we've set it up to look at the things that are most often missed with your doctor in preventive medicine. And the things that are most often missed, the biggest thing is insulin resistance, prediabetes, even full-blown diabetes. And if you want to figure out how to get that regarding yourself, the webinars are a perfect way to do that. It's a rifle shot issue. It deals with that specific item. It's relatively inexpensive. So we've got some specials. I think they're ending today on the webinars. In fact, maybe Aspen, if you will send an email to Chris and Michelle, that may have already ended, that special. But anyway, it's a great way to, without paying the extra expense of seeing me one-on-one, without maybe disrupting some of your relationship with your primary care doc, to just find out that one thing. Do I have cardiovascular inflammation? Or more importantly, And more commonly, do I have insulin resistance? Am I one of those over half of the adult population in the US that has insulin resistance and 90% that don't know it? Am I one of those groups? Am I one of those folks? Because if you are, you're burning your arteries. And we used to call that, quote, normal aging. Now we know it's clearly, you can stop it, you can even reverse it. There's also a webinar looking at plaque. Do I have plaque? Because if you have plaque, things are a little bit different. You need to know how to manage it. You need to consider things like statin and baby aspirin and stuff like that. And just doing a stress test is not that clear in terms of plaque. Go back and read the book. Well, that book will be out soon, and we'll talk about that in just a minute as well. So again, great way to access care, very cost effectively. Another cost effective way to do that is the memberships. We have more people signing up for silver and gold membership. Getting some one-on-one time, exam time is part of those activities as well. And of course, the courses are available. We tend to just make those part of other deals, other ways of accessing our content. I mentioned the error, the fallacy of saying, you know what, do I have plaque? Do I have risk for heart attack and stroke? And hey, doc, why don't we get a stress test? Tim Russert was the poster boy for that fallacy. He had a normal stress test. What was it? April, March. Went back to work and 3 months later died from a heart attack. So there's a whole lot more of the science behind that and why that happens. The bottom line is it takes over 50% occlusion to show anything, to show results, positive results on a stress test. 2/3 of heart attacks occur with less than 50% occlusion. So there's got to be a better way. And again, that's what the plaque webinar is all about. Regarding the website, we never really put that much effort into the website. It was what's called a brochure website, and we didn't get a lot of attention to it. It was basically to help people that were looking to sign up for services and help them understand what the services were. About 6 or 8 months ago, we started putting some focus into making the content available on the website. And we're seeing great results. A year ago, we would average about 10 visits a day. Yesterday, we had 600 visits to the site. So again, momentum's picking up. People are beginning to realize and understand that content's out there. And you don't have to be able to listen through my slow Southern drawl. You can find it in writing. So we will actually be covering one of those items that we have a blog about, vitamin K2, as soon as Aspen hits the water ball for us. So vitamin K2, you see some buzz about it, but you don't see a whole lot of clarity regarding what's the real science? What's the real mechanism? You hear people say, well, you know what? It takes calcium out of arteries and puts them in the bone where they need to be. How would it do that? Well, there's a lot of interest, but not a lot of information out there. Let's go back and talk about that and talk about what it might be. And just as a brief spoiler, it might be a little bit of both. So 1935, there was a Danish biochemist named Carl Peter Henrik Dam. He described a food additive that reduced bleeding in chicks fed with extremely low-fat diet. He named it vitamin K. Why vitamin K? Because the German word, and he spoke German, for coagulation or clotting starts with a K. So he called it vitamin K. A few years later, an American biochemist, Edward Adalbert Doisy, determined that vitamin K's chemical structure and succeeded in synthesizing it. Dam and Doisy shared a 1943 Nobel Prize for their work on vitamin K. Now remember, this is vitamin K, not vitamin K2. And we're talking right now about that original vitamin K, which is integral to clotting or coagulation. That's actually phylloquinone, vitamin K1. And you see the, for those of you who are biochemistry geeks, that's the biochemical, that's the molecular arrangement. As you start looking at vitamin K2, you begin to see that the menaquinones, the vitamin K1 is phylloquinone, vitamin K2 are the menaquinones, and there have been multiples described. The two that are most commonly known are menaquinone 4, or MK4, and menaquinone 7. Now, one of the things, again, if you get deeper into the biochemistry, you start seeing that the vitamin K2 variations have a lot more of these double bonds. That's about as far as I'm going to get into the biochemistry and the molecular structure. Now, vitamin K2 does affect bone growth, the loss and growth, the deposition, and the taking back up of calcium. Simply adding calcium to your diet doesn't ensure bone growth. Other factors are involved, like hormones and vitamins. When talking about calcium absorption, we think first of vitamin D3, and it is critical to absorption. But K2 plays a factor. Now, again, we're talking right now about bones. We'll go back and we'll connect this whole thing about vitamin K2 and bones and calcium in just a few minutes, but be patient with us as we get there. K2 activates osteoblasts. Osteoblasts are cells which build up bone. For those of you who've been through physiology, you can remember blast has a B in it, and B stands for build. Clasts, osteoclasts, has a C in it, and that means to cut away or to decrease. Osteoblasts are cells which build up bone. Osteoblasts produce osteocalcin. And osteocalcin is a protein or an enzyme with important roles in bone mineralization and calcium hemostasis. It's activated, it's very much involved in the activation of K2. K2 is involved in the activation of osteoclasts and osteoblasts, and osteocalcin is a part of that process. And the process overall is what's called a carboxylation. Again, for you organic chemists out there, it's a carboxylation process, which, again, here's where vitamin K2 comes in. That carboxylation does not occur without vitamin K2. K2 inhibits osteoclasts, as we mentioned before. C cuts, so osteoclasts take calcium away from bone, and it inhibits those. Osteoclasts are cells which remodel bone by removing calcium. K2 also activates MGP. MGP is an acronym standing for matrix GLA protein. MGP is another protein which helps to ensure that calcium is used in bones and not deposited in arteries and other tissues. Now, scientists have noticed that vitamin K2 supplementation does improve prediabetes. So again, you hear so much information about, well, K2 gets takes calcium out of the arteries and puts it in the bone. Yeah, but there's another way, which to me, I wonder if it's not even more important. You may have heard the term pleiotropic mechanisms. Actually, I talked about that in one of my videos. Pleo means many, and trophic means to go to. Statins have pleiotropic mechanisms. Not only do they have multiple mechanisms. So not only do they decrease LDL, they also decrease inflammation in the artery wall. Well, vitamin K2 seems to have pleiotropic mechanisms as well. Not only does it impact calcium in the artery tissue and the bones, it appears to have something to do with insulin sensitivity. In 2010, Diabetes Care Journal, and here we've got a link here if you're watching this on a large screen. Here's the article: Dietary phyloquinone and minoquinone's intake and risk of type 2 diabetes. Dr. Jolene Boylans, she's a professor of lifestyle and cardiometabolic disease epidemiology at the Amsterdam Public Health Research Program. Her research is focused on nutrition, cardiovascular health, and prediabetes. She's been involved in several studies demonstrating that K2, or the minoquinones, have a preventive effect on prediabetes. This work on vitamin K2 prediabetes is still not completely proven, but there are meta-analyses already which support this. As I mentioned before at the beginning of this, I thought I had found maybe the only randomized clinical trial that mentioned this, and I found it buried one place in some really arcane literature. But as you go back and you look, there's actually even a meta-analysis. What is a meta-analysis? For those of you who don't know, it's looking at multiple pieces of research, multiple trials, and these trials looked at this specific question. So the title of that article is Effective Vitamin K2 on Type 2 Diabetes, a review. The study showed vitamin K2 intake reduced 7% the risk of type 2 diabetes with each 10 microgram increment. 7% doesn't really sound like a whole lot until you start looking at with each 10 microgram increment. So the question is, at least from the signals seen in this meta-analysis, significant, very significant, powerful impact. Vitamin K2 has a more significant impact than vitamin K1 on type 2 diabetes. And again, as I've mentioned from the very beginning, I felt like some of the original studies that talked about K1 and diabetes probably were confused over K1 versus K2. That remains to be seen. Vitamin K2 increased insulin sensitivity via osteocalcin metabolism. It improved insulin resistance via anti-inflammatory properties and lipid-lowering effects. Once you get a little bit deeper into the anti-inflammatory properties and the lipid-lowering effects, you might see, and we cover that in some other videos, some other blogs, you might begin to wonder, like I do, maybe it's not the lipid-lowering effects causing the improved insulin resistance. It's probably the other way around. The improved insulin sensitivity is causing improvements in lipids. Lipids, in case you don't know, pardon the technical term, cholesterol and triglycerides on a practical basis. You improve insulin sensitivity. You improve HDL, the quote good cholesterol. You improve LDL, the quote bad cholesterol. In fact, you improve triglycerides. So that actually is a deep topic. I just finished a blog update on triglyceride over HDL ratio. That is a very, very interesting topic. I gave it to Chris last night. He'll be working on it. And hopefully we'll be putting it out and covering triglyceride over HDL ratio and the impact of triglycerides and the fact that HDL lipidology is very confusing, but there's some very important life-saving information in there. So we want to boil it down, make it palatable, make it digestible. Enough on the triglyceride to HDL ratio. Again, this is where I went down that bunny trail. Improved insulin sensitivity, and we'll talk about that in that next video. Improved insulin sensitivity decreases triglycerides. When you decrease triglycerides, you increase the HDL numbers. You increase the large fluffy HDLs, which are the ones that really help. And you actually move your LDLs back up in the proper direction, away from the small, dense atherogenic SDLs up into the larger, fluffier LDLs, which do not cause plaque. So back to vitamin K2. It also suppresses inflammation, inactivating the nerve kappa beta signaling pathway. Now, is that associated with insulin sensitivity? I don't know. That's a little bit deep for me. We were going to cover this video. It's a quick 1-minute video. It's been a very popular republication of a discussion on vitamin K2. But I thought, you know what? That's enough of me. Let's go ahead and go to the Q&A. Aspen, if you... So there we go. Hopefully I've muddled through and wandered around this topic at least well enough to get some acknowledgement, some understanding of what's going on. Got a lot of folks here today, a lot of interest, and again, K2 is always a very interesting topic. I'll just start off with the question, do I take it? Yes, I do. How much? We get that question a lot. Most supplements, you'll get like these K2, D3 supplements, and you'll typically see 100 micrograms of K2 in that supplement. The randomized clinical trials that I've seen that actually impacted insulin sensitivity actually used 300 and 400 micrograms, and that's closer to what I'm taking. I take a regular supplement. Didn't think to bring the tablet in today, but you can get it in our systems. We've done a lot of work improving our supplements access programs. And again, either I or JR can help you with that, or you can come to the supplements webinar. We've got a webinar on that as well. Now, I tend to take 200 micrograms per day, or I take 200 micrograms per day in a supplement, but I also have a morning smoothie, which I put natto in, natto powder. Natto, you may remember, is really ooky, bad, vile tasting stuff, at least for most of us. And it was for me for the longest time. When I was the medical director for Toyota North America, I got the chance to visit Japan a few times and tried natto, and it was really bad. Now, when I say that, I get a lot of comments from people that say, no, they really like it. I haven't even really acquired the taste. I can tolerate it now. But anyhow, what I do is I get a bag of fermented soybean natto powder off of Amazon. I put a teaspoon of that powder in my morning smoothie. The morning smoothie doesn't have significant calories. It's more of a supplement type of smoothie. And we can cover that again sometime. Someone was asking me about the contents of that. I've got a video that talks about my morning smoothie if you want to take a look. It's a little bit old. I don't know if it includes that natto powder or not. But let's get to some questions. Bart, thanks for joining. And John Tocho, good morning, Doc. I have my echo this afternoon to check on my mild aortic stenosis. I didn't know you had that. Thank you so much for sharing it. Oxygen, 99%, so that's an O2 sat. 84 was my month of August average for Freestyle Libre. Excellent. And I hope you confirmed that a couple of times. Freestyle Libre can be a little bit off. Thank you for all that you do. Thank you, John. I appreciate it. The one comment I want to make, I had someone come in that had been working with a Libre, one of my patients, and again, had very unrealistic expectations, had a number down, probably off by about 5 several times. And he said, this Libre is not accurate. Guys, wait a minute. Let me give you an example. The vast majority of people that come in as full-time patients in our core lab panels, we'll end up looking at fasting glucose 2 different ways. One is through the metabolic panel, The other is through the OGTT, and insulin survey. Both of them include a fasting glucose. Now, this is typical, and in over half of folks, we'll see a variation of 5 and even up to 10. Now, let me go back and give you some perspective on that. This is the same patient, the same blood, the same draw, the same stick, the same technician doing the blood, and the same quote lab, Quest, and it's a national reference lab. They're a great lab. And yet we get variation of 5 to even 10. Yes, that's the sort of variation you can expect. So you'd say, well, I'm not going to use that. That doesn't tell me the exact number. You know, that's the state of the art, folks. You need to learn how to approach labs with some idea of skepticism. When you see some potential for being off, you need to know what to do. And the most common thing and the most important thing is to have a finger stick method with you at the time that you have that. So John, thank you so much for sharing that. And it sounds like you're doing great. My BJJ, $5 super chat. Thank you so much, BJJ. We appreciate that. Some believe K2 can reverse aortic valve calcification for those with a stenosis. There are no clinical trials, but one is in recruiting stage. Any thoughts on this? I've been on it for 10 months of my AS, aortic stenosis. Thank you, BJJ, for sharing that you have aortic stenosis. And, you know, I have to tell you, it's a guess, but it's what I mentioned early on. I will be very skeptical that K2 is as powerful and as helpful as I think it is. I'll be skeptical that it could actually significantly reverse aortic stenosis. But here's the thing: if it can stabilize and prevent insulin sensitivity and even improve insulin sensitivity, who knows? If I had aortic stenosis, I'd be tempted to try it. So thank you again for the question. Very, very interesting. Thanks at BJ. John Tocho saying he takes K2. BJJ, my stenotic aortic valve area went from 1.0 centimeters to 1.1 centimeters in 14 months while on K2. That is within margin of error, correct. So what that means for those of you who got lost on that, within the margin of error means that we're not you can't really be sure that that was a major substantive change. That might have just been a variation of the measurement method itself. Just like we were talking about the margin of error a few minutes ago with blood glucose. It's even 5, maybe up to 10 at a great lab like Quest. So when you see a variation on your Freestyle Libre, don't over stress on that. Start looking at patterns. The patterns is what's appropriate and important. Because of the margin of error, don't set up your insulin treatment or anything like that based on it. So that's within the margin of error, and pressure gradient has increased. So that makes you, if the pressure gradient has increased, that makes you think that maybe there has been some actual physiologic increase of that aortic stenosis. So I'm doubtful it helped. I would, as I mentioned, I would be doubtful as well. John Tocho, thank you so much, John, for the super chat. So, Douglas D, the heart loves fatty acids. It's a good point. People tend to think that the whole body runs on glucose. No, the heart, the brain can be trained to go on that, and it probably does better on fatty acids, and the heart clearly does better, doesn't need to be trained. Thank you so much for sharing that. Carolyn Rogers, hello. Hello to you, Carol. Ibtihaj R. Hi, everybody. Hello, Ibtihaj. Hope, and sorry if I mispronounced that name. Douglas D. I had an RN tell me to lay off the K2, but she's only a nurse, not full-fledged doc. Well, thank you for sharing that, but don't be too quick to assume that doctors know this stuff. The vast majority of doctors don't go that deep into supplements or even nutrition at all. It's just not been part of medical education. Art Berry, I take K1 and K2, have type 2 diabetes. Well, I have prediabetes and I take K2. And you know what? Most of us, once we get beyond 30, clearly beyond 40 and 50, start getting this problem, prediabetes. So I think K2 is probably something that maybe most of us should be considering. My BJJ found out about my aortic stenosis 14 months ago. They thought it was my very high LP(a), but found out I have a bicuspid or aortic valve. Oh, so interesting, which causes early calcification, and I'm 53 years old. Very, very interesting. So if you're okay sharing, let us know what level of LP(a) you have. Joe Riley does some work with us. He shared with us on the channel. He's got some very high levels of that. So, and I think in the family, there's a few folks that have had calcified aortic valve. And you're right. That's one of the things you look for with these really, really high levels. But then you go in, you take a look, and yours was not the LP(a). It was a bicuspid valve. I guess what I should do is maybe talk about or at least clarify bicuspid versus tricuspid. Usually the aortic valve has cusp, means leaf in the valve, and I'm doing this. I don't know if that's going to help very much. Maybe look it up on Wikipedia. The tricuspid, the three-leaf valve, is what the vast majority of us have, and that three-leaf valve gives it more opportunity to open up. A bicuspid valve is more like this, and it doesn't give it quite as much flexibility for opening up to get that blood across the valve level. Thank you so much for sharing that, BJJ. David Raystrick, hello. Doug Smith, can one have insulin resistance if thin and athletic? Ran 19 miles in the last 2 days. Doug, this is the channel for you. I have, for the past 30-something years, never had a BMI over 22. I am a marathon runner. Not so much anymore, but I've run, what, maybe a dozen marathons. I have no idea how many half marathons, and even an ultra. And it was, what, maybe a year or so after my first ultra, or after my ultra marathon, that I discovered my significant prediabetes. So I hope that answers your question. Marathoners get prediabetes all the time. It has more to do with aging than obesity. Obesity is very important. It's more reversible than aging, obviously. But Doug, yes, take a look at some of our videos. Marathoners, and I've got several metabolic doppelgangers, guys that, again, big marathoners with significant prediabetes, even full-blown diabetes. Age 73. Yep. Read the book. There's a very interesting book on this. It's not specifically on marathons, and if you say, well, it's got to be about athletes, this wouldn't be the book, but couple of books. One is Blood Sugar 101 by Jenny Ruhl, R-U-H-L, or The Diabetes Epidemic and You by Joseph Kraft. These are both classics in this space, and basically what they show us is by the time we're age 60, way over half of us have this problem. If you think you're going to outrun it, think again. And here's the thing. A couple of things I'll just share with you stuff that I've shared with folks on this channel multiple times. One of the questions you have to ask about, well, again, marathon or ultra marathon, why would I have diabetes or prediabetes? Keep that fat level way down. And then here at age 63, I still have a size 32 waist. So it's not fat, it's aging. There's a couple of other things too. I was a 10.5-pound baby 63 years ago. We used to think that was a fat, healthy, happy baby. But what we have found over the past couple of decades is that babies that are that fat have a greatly increased probability of having prediabetes and diabetes as they age. The concept here is called epigenetics. And we've got we go into a lot of that science too. It's called the methylome, methyllome, the methylome. That the genetics needs this, if you've got what, 6 billion base pairs in your genetic code, then you really need a good librarian to go back and figure out, okay, this is the gene for, one of the proteins we've talked about. This is the gene for ApoA1, which is the protein in HDL, or this is the gene for LDL. Actually, LDL uses one gene and it cuts it off, 148, etc. But that's a bunny trail. You need a great librarian to figure out how to find all of those genes, and that librarian depends on methyl. It methylates areas of the genetic code. So when I was in the womb and getting way too much blood glucose, resulting in me laying down way too much fat, my genetic librarian was methylating a lot of genes that are now coming back to roost, back into function, which, even though I was running marathons, took me on into full-blown, well, I'm not going to argue about full-blown diabetes. It's very significant prediabetes, very significant diabetic metabolic tendencies, difficulties metabolizing glucose. And again, this goes back to when I was in the womb. So very interesting stuff, and we continue to find more and more. Another issue about epigenetics, and a very interesting issue, which we don't understand at all yet, and that is, if you take lab animals, laboratory mice, and the father is obese at the time of fertilization of the egg, not only the offspring, but the grandchildren of that offspring have much higher risk for diabetes. So, Doug, there's a lot more going on here than body fat. There's actually a lot more going on than age. There's some epigenetics, which we just don't completely understand yet. C. Lear, thanks for educating us. Is high LDL with low small particle size, LDL, okay? Yeah, oh gosh, talk about throwing a piece of meat into a pack of dogs. There's a lot of argument and debate over that. Most of us would say, yes, it is okay. And I would tend to, well, most of maybe the folks that have studied LDL recently, and I would be one of those. Yeah, it's the small, dense LDL that are real problems. And again, this gets back into some maybe a bunny trail I started to go down earlier, and that is, why does triglycerides, number one, why does insulin resistance cause increased triglycerides? We'll talk about that again later in the upcoming blog and video. And then, why does increased triglycerides cause decreased HDL size? And why does it even causes decreased LDL size, which most people don't understand? I actually go into a picture of one of my patients, not the patient, not any of their identification information, but we show you their triglyceride over HDL ratio, which is, in this case, 7. Then we show that there's a major chunk taken out of the magnetic resonance imaging of the HDL. It's just, you can see where there was a beautiful bell curve showing the population of HDL particles. The large ones are just taken out. Then you look over at the LDL, and again, they've got a good bell curve pattern, but that whole pattern is moved over to the left, where it's much more small, dense LDL. You know, there's a great series of podcasts by Peter Attia, and he's interviewing Thomas Dayspring, and Dayspring is one of the guys that looks at this issue. And what it appears to be is this. So why does increased triglycerides cause smaller, denser HDL and LDL? There's a thing called CETP, cholesterol ester transfer protein. And what it does is it will take cholesterol esters out of large HDL particles. It'll take them out of large LDL particles and transfer that for that triglyceride. So if your body's making too much fatty acids, triglycerides, those fatty acids tend to get transferred from the VLDL, the remnant cholesterol, and the chylomicrons, mostly the VLDL. So when that triglyceride is taken out of the VLDL, well, maybe I'm getting a little bit too technical here, and maybe I'm confusing the situation. Bottom line is, triglycerides begin to replace cholesterol in these lipoprotein particles. When they do, the liver lipase will take that particle up and digest it, pull out the triglycerides, leaving all of those large fluffy HDL and large fluffy LDLs that used to have cholesterol in them are gone. That's what happens. And thanks for your patience if that got a little bit too technical. Thank you so much. Amer Al-Gayer, hi from Germany. Hello, Amer. Great to hear from you. My BJJ, thank you again so much for the super chats. As Aspen has shown, we've got Patreon, we've got a couple of other ways to contribute, and we really appreciate it. Bottom line, the biggest thing we would love for you to do is maybe get a course, maybe even get a webinar to find out about yourself. How much of these problems do you have? Do you have insulin resistance? Do you have plaque? That is critical, life-changing information for you as an individual. Robert Simpson, good morning. Good morning, Robert. Good to hear from you. Robert's often on the channel. Magneto Pulse, love your channel. If one is recovering from an event 1 year ago with stents, is K2 risky? No. So here's the rest of that question. Is K2 risky in that it might destabilize existing non-stented plaques? You see this comment, this question quite a bit. And actually, if you look back on my videos when I first started looking at K2, I wondered about that as well. John Lorscheider, when he was active with our channel, felt very strongly that that was a potential possibility. The more I study this, the less I believe that K2 is actually going to destabilize a plaque. A couple of things. Number one, as we mentioned already in the program, K2 helps decrease insulin resistance. So insulin resistance is not going to destabilize a plaque. And here's the other thing. If you're removing plaque, so John's video was a great example of this. He actually decreased his calcium score by what? 59%, 60% over a 18-month period. We had another video from another volunteer named Jerry Kurth. He reversed his calcium score by about 20%. And here's the thing. Does anybody think that either John or Jerry actually destabilized their plaque when they removed the calcium? Not at all. These guys lost, in John's case, he lost like 40 pounds. Jerry stabilized a lot of things. It was clear from the rest of the case discussion for these individuals, they were clearly getting more healthy, not less. So, yep, if you lost 30 pounds, you start reducing some of that plaque, or lost 40 like John did and start reducing some of that plaque, the calcium that way. If you gained all of that weight and you got a decrease in calcium, yes, I would be worried that you've destabilized your plaque at that point. But when you're doing it by K2 and weight loss and some of the things that we know improves your health, I don't think that's going to destabilize the plaque so much as it is just naturally and safely reverse it. So we have, we're losing track. We've got a lot of comments coming in. Here, my BJJ, do you have an opinion on the timing for bicuspid? No, I don't. Sorry. Timing for bicuspid aortic valve surgery. 2 camps, wait as long as you can, but get SAVR once symptoms present, or number 2, better to get the SAVR before symptoms. I'm sorry, BJJ, I do not have an opinion in that space. Farouk Farr, is K2 a blood thinner? Thanks for the information, Dr. Ford. K2 is not a blood thinner. You don't have to worry about that. You don't have to worry about it interacting with blood thinners that you might be taking. K1 is the blood thinner. And unfortunately, since they're both called K, which originally, as we discussed, came from coagulation, the German spelling, people really tend to get confused about K2 and blood thinning. It does not do it. It's inert in that area. Magnetopulse, are you aware of any Baildenine practitioners in the south of France? Magnetopulse, I'm jealous if you're in the south of France, or if your family is, or you know somebody there. I do not know any Baildenine practitioners in the south of France. I will say this, though. I've been a Baildenine practitioner for quite a while, and I've got patients in London, Brazil, New Zealand, which, for those of you who don't know, it's in Australia. Got patients in Israel. So I've got a fairly global reach, Magnetopulse, and I'd be, if we can get time on the docket, I'd be happy to see your friend or yourself. Shakir M, is it permissible to take vitamin K2 without doctor's consultation? Yes, it's an over-the-counter, non-prescription vitamin supplement. Mary Laborde, my husband and I take 300 micrograms of K2 daily. I think that 2.0 was supposed to be the digit daily. Thank you for sharing, Mary. IGA 0117, yeah, what's K2? Without going through those details again, I would suggest maybe you want to go back and take a look at the video. And we've got about more than a half dozen other videos on the channel on K2, what is it? In fact, look up Ford Brewer, YouTube Ford Brewer, vitamin K2, what is it? You'll see that level of video, vitamin K2 101. Trav Barber, how is John's efforts towards reducing his calcium score going? John has disappeared from the roadmap. He's, as he said, I'm going dark. You probably won't see or hear from me for maybe ever. I'm focusing on my on some personal stuff, so I'm respecting his request and his privacy. Mary Laborde, K2, not K. Okay, thanks. Yeah, that's what we thought. Thank you for the clarification. Ego 0117, that sounds like a skiing product. K2, you know, there's a mountain that a lot of people are excited about climbing, K2. So yeah, you're right. Sounds like a skiing product. Ibtihaj Air, they say propolis makes wonders for diabetes and heart strokes, isn't it? Not sure. I'm not familiar with propolis. Is that real natto? I think you're asking, is the powder that I'm taking real natto? It certainly appears to have significant K2 in it, but I think that's a great question. I have not been able to verify. Trev Barber, any concerns with soy and natto kinase? Natto kinase and natto are not the same thing. Natto kinase, there's another term for it, and it's made from a substance in moth saliva. It's what the moth uses to get out, chew its way out of its husk, of its cocoon when it's emerging. So natto kinase and natto are not the same thing. Thanks for the question, though. Any concerns with soy? And I think maybe the question is concerns with soy. I know there's a lot of perception that soy increases hormones, especially female-related hormones. I've not gone that deep in terms of that issue. I know that soy is a huge product in America. A lot of my family are soy farmers, chicken farmers in North Carolina. Did a lot of work with Toyota. Obviously, those, soybeans, they just eat them as part of a lot of meals. I've not seen anything that would substantiate. Yes, there does appear to be, when there's smoke, often there's fire. There does appear to be evidence that there's some relation there. I don't doubt that. I don't argue with that. What I do doubt is significant health impact from soy. And I know when I say something that clearly, I'm going to get a lot of haters, because there's a lot of folks that are soy haters. I'd love to see see the evidence, the citations, the actual evidence. Thank you much. Rook Stockpicker, my cardiologist doesn't believe you can lower calcium scores. I know. He says it's just a way to sell books. I know. I see that a lot. And in fact, I've got a video that is titled, "My Cardiologist Says This is Impossible." And one of the things I do in that video is go to the actual science. I'm not saying this. I mean, I've documented a couple of cases, and yes, we've talked about that. I don't have any books on that to sell, by the way. Suggest your cardiologist take a look at the actual science, and I've got the references in those articles. This was a cardiologist in LA that this doc was referring to, Cedars-Sinai, I think. And he says it's impossible to reverse plaque. And, one of the citations was simple. This wasn't even hard science. One of the citations is simple, easy, Harvard Health, which is written for the lay public, not for the medical public. And the docs at Harvard Health are talking about, yes, we have seen it. It's not impossible to reverse plaque, just like it's not impossible to reverse a calcium score. So thank you, Rook. Great point. I'm glad you brought it up. Gave me an opportunity to go down that bunny hole. Bart Robinson, I'd rather go to another cardiologist if he told me that. We see a lot of that. Thank you, Bart, for the response. Jim Clark Sr., any experience with concentrated K, which is 5,000 micrograms K1, 25 milligrams K2, MK4? No, I have not had experience with that. 2 milligrams astaxanthin. It's been prescribed by an internist for me. My cardiac calcium score is 2009. It's 209. No, I'm not familiar with that, and I'm guessing you're obviously not on a K antagonist. That's one of the drugs that it's a blood thinner. These are a class of blood thinners which decrease the impact of vitamin K1 in the coagulation area. And I'm saying that because you're talking about concentrated K having 5,000 micrograms of K1. Jonathan Hull, do you have patients that use a continuous wear pulse oximeter to measure overnight oxygen levels? I just heard about this. You know what, Jonathan? I just heard about this from your comment. I've never heard of that before. I think that's very interesting. Very interesting. Kevin Gold, what do you think is a safe maximum dose of K2, MK7, relatively high calcium score, okay, nuclear stress? You know, I don't think there's a whole lot of, there's clearly no evidence regarding any safety signals from K2. In other words, K2 appears to be fairly harmless. I don't, you know, then it becomes a question of, you know, how much makes sense. Like I said, I take relatively higher amounts. Is it going to hurt you to take 600 or 800 micrograms? I'm very skeptical that it is. If it did, I think there would have been, signals about that. Mary Laborde, natto, pronounce it as natto. Oh, I'm sorry, Mary. Thank you very much for the reminder. Like I said, I've spent significant, as in a decade, working 8, 10, 12, 14 hours a day with the Japanese. And I know that. Natto. And I've been saying natto. I wonder why I even went there. It's just your brain fails. Bart Robinson, good question, Kevin. I agree. Nam Rafni at Rook, because it's not in his interest if it's true. If it works, he'll lose a lot of. I think Nam's point is the cardiologist would say, yeah, if people knew they could reverse their plaque, they wouldn't come to see me. Yeah, I'm sure I constantly get surprised with some of the nefarious stuff that goes on, even in medicine. But, and maybe I should say especially in medicine, but the reality is it's not very common now. I would say that. I think that drives more of this perception that you can't reverse it than anything else. Danny, what's a high, safe daily dose of K2, MK7? I wouldn't think that, I'm just skeptical that significantly over 400 I haven't seen anything over 400 micrograms per day in the science, in the literature. I don't think, I don't see any evidence that, I'm personally not planning on going any higher than that. Kevin Gold, thank you, Bart. Patricia Morse, vitamin MK7, K2, help clean the arteries. Patricia, evidently you've just joined us recently. You may want to go back and view this video and a few others on K2 on this channel. Food lover, most cardiologists are just money mills. They maintain outdated and just wrong theories about heart disease to maintain their incomes. A lot of cardiologists are clearly that way. I'll just leave it at that. EGA0117, yeah, what cleans the arteries? Greg, without diabetes. Greg, I hope you're still without diabetes. That's a very interesting name. Wonder, where does that come from? When one gets a bad Libre button, does it not work or is it just inaccurate? It's usually inaccurate. Not all buttons are inaccurate, but when there's a bad button, it's usually because it's inaccurate. I just had one that was 20 points low, and that's what you tend to see. You'll tend to get these buttons that are 10 or 20 points low. You just have to recognize that, go ahead, acknowledge it, replace it, and move on. That's what happens in life. Food lover's right, and food lover was the person that was banging on cardiologists. No other comment. At least from me there. Bob Bell, Greg, WD, there are differences between capillary BG, venous BG, and interstitial BG, which is Libre. Thank you, Bob. So there's a thing called the choo-choo effect, and that is if you ingest some glucose, your blood sugar will pop up quickly in the blood, but it may take up to 20 minutes. And when it drops again, it may take 20 minutes, even half an hour to drop on the Libre. And it's because what we call the choo-choo effect. The choo-choo is this issue. You're not looking at capillary blood glucose or venous blood glucose. You're looking at interstitial fluid blood glucose, and it takes longer to get there. Not going to spend much more time on that. Thank you so much, Bob, for bringing that up. Rook Stock Picker had a stress test yesterday. I don't have results. I do know they took plenty of pictures, and they had to go through all 5 stages on the treadmill to get my heart rate up to 136. Well, Rook, the fact that they had to go through all those stages is a very, very good thing. Congratulations. My BJJ, I'm 95th percentile, LP(a), 97 milligrams or 243. That's a significant number, BJJ. As I've shared on many of my other videos, I've got lots of people with 500 and above. BJJ says it runs in my family. Well, of course it will. It's genetic. Grandpa died at age 52. He smoked and suspect this combined with the LP(a) is the culprit. You bring up a great point, and again, it's worth repeating. So like I said, I see a lot of people with significant elevated LP(a)s. Actually, a lot of other docs do too, but most docs don't look for it. So they'll often miss it. And, you know, we used to say not ready for prime time until Bob Harper had his heart attack. He was the guy on The Biggest Loser. And he announced a week or two later, yep, that was LP(a). And yep, I got that from my mom. His mom was in her 70s or 80s at that time and fine. And I will tell you this, that's exactly what I tend to see. Even a lot of these people with huge numbers, 400 or 500 plus, tend to do very, very well until and unless they add another major risk factor like obesity or aging, or in this case, and I've seen that several times too, smoking. So thank you so much, BJJ. That was a great contribution. James Cantor, Dr. Brewer, if you were thin and athletic, why do you think you became pre-diabetic? Well, I shared a couple of things about that. Number one, one thing I didn't share about it is I have a healthy dose of 9p21. What's that? Ninth chromosome, the p21 area. It's an area which used to be known as the cancer gene, as a cancer gene. It was also, if you've read that book, somebody mentioned Bale-Denine before, Beat the Heart Attack Gene. Well, the heart attack gene that Brad and Amy are talking about in that book is 9p21. It's actually pretty common. And what they don't go into, and a lot of people don't go into, is the fact that now we've found dozens of components within that 9p21 area. And major chunk of those components result in increased risk for diabetes. There's also some chunks within the 9p21 area that can cause increased risk of problems with the smooth muscle of the artery wall. Won't go down that bunny trail, but I'll go back and answer your question about me. So I've got a major chunk of, or major risk associated with 9p21. I was a 10.5 pound baby. My dad was north of 300 pounds when I was conceived. And I hit my late 50s. So I had a whole lot of stuff going on. And who knows, I didn't check. Maybe I had some significant peri-organ fat within my abdominal cavity. Don't know that, haven't looked. But I clearly had both genetic and epigenetic reasons to get diabetic early. Now here's one thing. One of my family members said this to me. She said, Ford, you've got all this stuff going on. Why is that? And the answer was, because I looked. And I knew what to look for. You know, the vast majority of people with my level of prediabetes have no clue. Over 90% of them. That same family member also mentioned to me at one time she's got major problems with ringing ears, tinnitus, depending on how you pronounce it. And did you know that ringing ears, chronically ringing ears, is a significant sign for significant prediabetes? So you know what? If you don't know what to look for, you don't think you've got it. Same thing with atrial fib. Vast majority of people that have atrial fib at my level would not know it, not have a clue. It's what I do for a living. Bob Bell, Greg WD, as Dr. Brewer mentioned, the same tech in the same lab can get blood glucose variations 10 plus on the same draw. Thank you. Bob, you obviously nailed it. You got exactly what I was trying to stumble through in that space. Last week, my Libre registered 75 at the same time a blood draw measured 91. Not at all confusing. I mean, excuse me, I didn't mean to say that. Not at all surprising. And that's the kind of thing that you have to be able to have the sense, the awareness, the knowledge to work through. Thank you so much for sharing that, Bob. We get so much confusion associated with this issue, this tolerance of errors and potential for errors in the Freestyle Libre. Greg Forbes, Xmas had quad bypass, no signs ever, low cholesterol 120 for 30 years. Had type 2 for 5 years, lost 70 pounds, changed diet, off insulin 100 units per day. A1C is now 5.7, cholesterol is 98. Do I need on statins? So, Greg, most people most docs go to recommend statins based on cholesterol level. And most of them look at 100. A lot of them look at, and we're talking about LDL cholesterol here, for those of you who are not aware. A lot of docs look at 70 or below, and you can argue on which guideline is more appropriate. I ignore those guidelines because I'm not looking at cholesterol level. I don't base recommendations for statins on a cholesterol level. I base recommendations of statins on whether or not you have plaque. If you've had plaque, you've had inflammation, if you've had an event, we know that you've had both, or it appears that you've got plaque, or they wouldn't have done the bypass. If you've got plaque, I would recommend consideration of a statin. And I know there's a lot of statin haters out there. I'm sorry about that. You know what? I'm a statin hater too. I knew I had plaque for about 3 years before I actually started mine. And there have been times, I tend to attract a lot of statin haters. There have been times when over half of my practice that had known plaque were still saying, I don't want to take a statin. And my perspective was, okay, I understand. I was there too. No argument. And we'd do the other stuff that we knew from more of a natural non-medication perspective. Thanks for sharing that you're that you're 72, Greg. 1957, Cato. It seems that beers and cheers works hard to rise triglyceride. Beers are a big deal. Too many carbs. Thanks for answering my question on LDL. Triglyceride HDL ratio is 0.67. Triglycerides 44, HDL of 69. Good for you, C. Lear. That is a great number. You know, you look up these numbers and they'll say, well, depending on your ethnic background, 2, 3, come on. You really need to have a goal of 1 or less. And you know what? There's a fellow named Chuck Smith. He did that. He did a couple of videos on that, shared with us. He was a patient of Dr. Caldwell Esselstyn. Esselstyn and the other guys that really hammer on getting fat out have saved a whole lot of people. Don't misinterpret this story in the comments. But he said, Esselstyn kept saying, get more of that fat out, get the nuts out, get this out, get that out. He lost 50 pounds. And then he had a heart attack. It was an exciting and quote fun story if you didn't go through it. He said, I was driving, I have a Tesla, I was driving it, I was going 55 miles an hour at Cocoa Beach. I knew I was having a heart attack. You know, you hear this story about a heart attack is like an elephant sitting on your chest. It felt like a whole herd of elephants sitting on my chest. Because of my history, I had some nitro tablets, but they were in the back seat. I did not want to waste my time and take the risk. So I put the Tesla in auto drive, turned around to the back seat to get my nitros. I got them and they spilled all over the floor. So I'm turned around backwards, picking up a nitro. The car's driving me at 55 miles an hour towards the hospital. He made it to the hospital. He did fine. And guess what? to go back, and why did I go down that bunny hole? So here's what started me on that story. Chuck, after losing all those pounds 50 pounds on a low-fat diet, and then having a heart attack, obviously got frustrated. So he started looking up channels, and he found mine, and he said, so I found this thing about triglyceride over HDL ratio. And I went and looked, and my triglyceride over HDL ratio, at the time that I had that heart attack, having lost 50 pounds, was still between 5 and 7. 5 and 7. No wonder I had a heart attack. So, and as you look at it, you start getting into the science. Many studies have shown that triglyceride over HDL is a much stronger indicator of risk for heart attack than LDL level. I know I'll get a few haters from making that comment, but you know what? It's in the science. Go look at the science. Go read it. Thank you so much, C. Lear, for sharing that. It was a great opportunity for another bunny hole. Shakir M. Thanks, Dr. Brewer. Thank you for your interest, Shakir. Bill Clifford. Could taking low-dose statin cause an increase in triglycerides? It's possible. Mine was 63 years. I'm 63-year-old ago. Now 122. Oh, mine was 63 a year ago, and now 122. Only change in meds was using low-dose statin Crestor. Well, two of the bigger questions I have, Bill, would be, what's your diet? Have you started adding carbs back in? And have you gained 10, 20 pounds? Both of those can have a very significant impact there. If the hard odge, yes. Oh, not sure what that means. Haters everywhere. Oh, isn't that the truth? You know, in fact, I finally ended up slowing way down on our daily COVID-19 videos because the haters just started coming out in droves. What happened, I think, was they found out that the COVID-19 virus just finds out which way you're voting before it attacks you. Pardon the sarcasm. Doc, or Richard Martell, Doc, you made an honest mistake. Nattokinase, like K2, both are derived from the natto bean. Serrapeptase enzyme is from a moth or a caterpillar. Well, thank you so much for the correction. And I'm not. Oh, you say the mistake was natto bean as opposed to soybean. Actually, you can make nattokinase, unless I'm mistaken, and I very well could be, because I'm not a natto. I see what you're saying. Nattokinase is also made from the fermented beans. Very interesting, Richard. Thank you so much for sharing that. And I would say I don't think it's just natto beans. I think you've seen it with black beans, soybeans, natto beans, and others. But thank you so much for clarifying that. PrevMed, reducing calcium score is impossible. Enterprise Lieutenant, everything was impossible until it wasn't. Captain Picard. Reducing calcium. Okay. Thank you for your response. That was from Jim Clark. Kevin Goldwood, low-dose aspirin, maybe half of a baby aspirin, counteract the effects of K7. K1. Again, K1 gets into the impact of bleeding, and that's what baby aspirin is about. It's decreasing your coagulation. It's an antiplatelet thing. It doesn't really decrease coagulation. It decreases platelets. That's maybe an over-technical differentiation. It makes a difference in terms of the medicine itself, but probably not worth diving into today. John Tocho, I've worn two Libre buttons during August, and they gave very close to the same results. That's why I posted the average for the month. Now on the third Libre button, and still the same range of readings. Well, thank you very much, John. And yes, you're right. You can get great, extremely practical information. Yes, it's got problems, but here's the thing. Would you rather fly blind? That's what we're doing. on something that is important as it is as important as blood sugar, when it is it's the thing that tells us whether or not we've got the major risk factor for the #1 cause of death, heart attack, the #1 cause of permanent disability, stroke, the #2 cause of disability, Alzheimer's, the #1 cause of kidney disease, the #1 cause of blindness. And we're comfortable walking around, most of us never knowing what our blood sugars are. Come on. Gail 716, would you share about your type of plaque you had and successful reduced? Was it concentric or eccentric? You know, I did not get that kind of, I did not get a, that's, you usually get that more with an intravascular CIMT. I mean, an intravascular IMT. Unless I'm mistaken, you don't really get really good clarification on concentric versus eccentric on the others. Now you can, but that's not what you usually get from a CIMT. And for those of you where this is sort of like gibberish, I'm probably going to leave it at that and move on. 3B balls. I take 10K D3 per day. My D3 levels are in the 80s usually. I tried K2 before, but it made my chest tight, cramp, so I stopped. Should I try to take it again? Yeah, you know what? I cannot help but remain a little bit skeptical that caused it. So I would try it a couple of times just to confirm, just out of curiosity, if nothing else. But Bart Robinson, Doc, you said K1 is a blood thinner. I'm sorry. Thank you so much. If you guys will please do that, fact check me, because sometimes when I get going, my brain goes that way. It went just the opposite, just as you said. K1 helps the body clot. That's where it came from, coagulation factor, coagulation in German. So it's not a blood thinner. The vitamin, the K1 antagonists are medications that cause blood thinning by decreasing the action of vitamin K1. Heparin, warfarin, those medications are K1 antagonists. Thank you so much, Bart, for helping me clear that up. Thoughts on the calcium score test? It's a great test. You know, it's very interesting. People think that I'm only into the CIMT, and I'm not. On a practical day-to-day screening basis, I don't think people should try to get a CIMT until and unless they know where they're getting it. Most CIMT techs don't know how to do it. Most CIMT providers don't know how to do it well. But the technology for calcium score is fantastic. It's very, very easy to regulate it, to make sure that what this person gets is the same thing that the next person and the next person and the next. It's standardizable. That's the word I was looking for. CIMT has huge problems with standardization. Calcium score does not. So I'll use calcium score a good bit, especially when we don't have access to a good CIMT. Ibithaj, eating meat at night causes insomnia for young people, which is a sign of a, do I have thoughts on that? I will say this, I mean, you look at the science, eating late before you go to bed is not healthy. DLB, belly fat, what is #1 thing you can do to significantly reduce? That's a really good question. They're clearly not just loss of weight and caloric restriction. You tend to get loss of fat in other areas first. Low carb diets have shown probably more impact than anything else. Exercise and low carb diets. Rook stock picker, they concluded that 92% of people with high cholesterol level lived longer and called for a reevaluation of the guidelines. Yes. Now the question is, who is they? Adir Nadal, clearly one of them, is the cardiologist that you see talking about that a lot. Mary Laborde, wow, thank you for that information. I did not know that K2 would also help Decrease insulin resistance. That's a great bonus. Thank you again for all your hard work. Thank you so much, Mary, for your interest. And guys, we have gone way over, and it's because we had so much interest. And because I had a little bit of flexibility with my time today. Actually, I've got a patient coming up soon, so I'm going to have to jump off. This is our last comment. Ramesh Kumar, best time to take K2 supplement, doc. I don't think there is a best time. I think you can take it in the morning, take it at night, take it in the afternoon, and it doesn't matter. Thank you so much, Ramesh. Thank you so much to the rest of you for your interest. It's a lot of fun when you get that kind of interest.